of early recognition of sepsis and the capability of saving someone's life. So thank you very much, Wella, for allowing me to do an opening kickoff for this session, this webinar.
Thank you so much, Kathleen. So before we begin our lecture proper, let's have a quick background first of what is this webinar all about. Okay, this is a 3.5-hour program. This is designed to empower nurses with the knowledge and skills needed to combat sepsis effectively. This learning session will tackle common challenges of recognizing and managing sepsis, focusing on the critical roles of nurses. In addition, this activity aims to provide nurses with an up-to-date guidelines and evidence-based practices for caring for at-risk patients with sepsis. Lastly, the participants will have a deeper understanding of how early recognition significantly impacts the patient's outcomes and can reduce mortality associated with this critical condition. This activity is celebrating the World Sepsis Day, which is held every September 13th. It aims to provide an opportunity for people worldwide to unite in the fight against sepsis. Sepsis accounts for at least 11 million deaths worldwide annually, yet depending on the country and education, sepsis is known only to 7 to 50% of the people. Likewise, it is a poorly known that sepsis can be prevented by vaccination and clean care, and that early recognition and treatment reduces its mortality by 50%. This lack of knowledge makes sepsis the #1 preventable cause of death worldwide.
Well, are you able to see the learning objectives? All right, so the learning objectives for this session are to clearly define sepsis and its severe forms and being able to recognize its impact. And I'd like to ask our tech host to please make sure that the Facebook link is running live. And if you could put that out there on Facebook, I would greatly appreciate that. Thank you. We're also going to recognize individuals and the conditions that increase their risk for sepsis. It's important for us as clinicians to be able to recognize those patients at higher risk. And we're going to talk about being able to, what kind of tools are available, and other clinical signs and symptoms to help you identify the subtle clinical components that the patient has. And then be able to apply the Sepsis 6 bundle principle for rapid assessment, as well as intervention. And then confidently administer fluids, antibiotics, and vasopressors as indicated. And then be able to interpret those vital signs and the lab results to be able to continue to guide our ongoing sepsis management in our patient. And it's really important to collaborate. So another objective is the ability to collaborate with the healthcare team for optimal patient outcomes. Excuse me. And then lastly, to provide essential information about sepsis and its prevention and assistance with recovery planning.
All right, thank you, Kathleen, for continuing it. So before we begin to our lecture proper, we will be having our pre-test first. So kindly scan the QR code here, and we will also be sending the link in the chat box for better and easier access of.
Is that the Facebook link or is it the pre-test?
It's the pre-test.
Okay, we need the Facebook link, please.
Okay, Kathleen.
Thank you.
The Facebook link that we're using is the Sisinapi page. So those who would like to view it through Facebook can go to Sisinapi page.
All right, once again, we are using the CCNAPI page for our Facebook Live. So those who would want to see the live, just visit the Facebook Live of the CCNAPI.
We are just waiting for the approval on the notification of the Facebook, so bear with us.
Thank you, Belle.
All right, thank you so much for answering our pre-test. So let's proceed to the introduction of our speakers. It is our pleasure to introduce our two esteemed speakers for this morning. Our first speaker is a distinguished Philippine registered nurse with specialized certification in infection prevention and control from APSIC, or Asia Pacific Society in Infection Control, and the clinical research from ISARIC, International Severe Acute Respiratory and Emerging Infection Consortium. With a strong educational background, including a Master of Public Health degree from University of the Philippines, Sir Phil has established himself as a leader in the healthcare industry. Currently serving as an infection prevention control supervisor at the medical city, he brings a wealth of experience to the table. His expertise spans various areas, including outbreak management, research, and public health. As published author and speaker, Sir Phil has shared his insights on infection prevention and control, inspiring others to prioritize patient safety and quality care. Notably, Sir Phil is Emeritus Awardee year 2022 at the Medical City, recognizing his outstanding contribution to the field. His research paper, The Effectiveness of a Dedicated Central Venous Access Care Team to Prevent Catheter-Related Bloodstream Infection in Private Hospital, has been published in Science Direct, showcasing his expertise in infection prevention and control. With this extensive experience, certification, and research background, Sir Fortune Charles Phil V. De Lara is a valuable asset in the healthcare industry, particularly in infection prevention and control. Our second speaker is a consultant nurse in critical care of Frimley Health NHS Foundation Trust in the United Kingdom. He is also a qualified advanced critical care practitioner and associate member of the Faculty of Intensive Care Medicine. He has a wide range of clinical, managerial, and academic experiences within healthcare. External to the trust, he is a professional lead for critical care at the Royal College of Nursing. He is also a former chair of the UK Critical Care Nursing Alliance, which is the alliance of all the critical care nursing organization in the UK. He is currently a board member of the Center of the Perioperative Care and represents the Royal College of Nursing at various other national committees such as FICM, Critical Care Leadership Forum, UK Critical Care Nursing Alliance, Intensive Care Society, Standards and Guidelines Committee, and Royal College of Physicians Independent Advisory Group of News 2. He is also visiting lecturer at Brighton University, where he lectures on topics related to critical care. He has led initiatives improving care for patients with sepsis locally within his trust and has also worked with NICE, NHSE, AOMRC, and NCE POD in various sepsis work streams. As a renowned expert, professor, and speaker, Suman has presented at various national and international conferences, sharing his insights on critical care, sepsis, and long COVID. He has also published numerous papers and contributed to several national projects and guidelines, showcasing his commitment to advancing critical care nursing. With his extensive experience, expertise, and passion for education, Suman is a true leader in the healthcare industry. Let us all welcome our second speaker, Dr. Suman Shrestha, MBE, and learn from his remarkable journey and contribution to critical care nursing. So with that, let us proceed to our topic 1, entitled Localizing Sepsis Care, Philippine Strategies for Recognition and Assessment. Ladies and gentlemen, nurses all over the world, let us all welcome Fortune Charles Phil V. De Lara, RN, IPCC.
Good morning, Mumuela. Thank you for the kind introduction. Also, thank you to CCNABI and the World Federation of Critical Nurses for inviting me on this uh, webinar. So let me just share my screen. So can anyone see my screen now?
Yes,
Yes,
Sir Phil,
okay.
we can see it.
Thank you. So good morning. Today I'm tasked with presenting, sorry for that, localizing sepsis care and Philippine strategies for recognition and assessment. So for the declaration, I have no conflict of interest to declare. Our objectives this morning is to describe the strategies for recognition and management of sepsis in the Philippine context. Also to share best practices regarding management of sepsis in the Philippines and to describe and compare various recommendations for management of sepsis locally and internationally. So to start, I'd like to always start with the epidemiology. So for the epidemiology of sepsis, so the WHO states that the global epidemiological burden of sepsis is difficult to ascertain, but the disease is thought to affect 30 million individuals globally and puts at risk of death some 6 million of the said people. So the incidence of sepsis all over the world had been reported to be 22 to 240 cases per 100,000 persons. So this validates the uh, uncertainty to ascertain the global burden of sepsis. On the other hand, the incidence of septic shock was estimated at 11 per 100,000 persons. It's also the one of the leading causes of death among hospitalized patients with case fatality rate of 30% for sepsis and as high as 80% for septic shock. So you're 30% likely to die if you have sepsis and 80% for septic shock. For the WHO also released a global report on the epidemiology of and the burden of sepsis, most especially related to healthcare associated sepsis or what we call the HA sepsis. So for HA sepsis, 1 in 4 cases of sepsis were acquired in the hospital. And then 24.4% mortality of patients with hospital acquired sepsis. You also have a 52.3% chance of mortality among ICU related patients with healthcare acquired sepsis and your 2 to 3 times higher median length of stay with patients on hospital acquired compared to community acquired sepsis. So you're more likely to be hospitalized for a longer time if you have hospital acquired sepsis compared to community acquired sepsis. And up to 1/3 of hospital-acquired sepsis cases were caused by drug-resistant bacteria. So the sepsis 3 definitions drastically changed the paradigm of sepsis with its publication in the Journal of American Medical Association, or the JAMA, in February 2016. Before sepsis 3 publication, sepsis was known as a syndrome resulting from the host response to infection. Its definition was based on the systemic inflammatory response syndrome or the SIRS developing from documented or suspected infection. The SIRS criteria needed to have at least 2 of the following. Either you have a temperature of more than 38 degrees or less than 38 degrees Celsius, a heart rate of more than 90 beats per minute, a respiratory rate of more than 20 breaths per minute, or a partial CO2 of less than 32 mmHg. Also, a WBC of more than 12,000 cells or less than 4,000 cells or 10% of immature band forms. Severe sepsis was defined as sepsis with organ dysfunction, hypotension, or signs of hypoperfusion, while septic shock was identified as sepsis occurring with acute circulatory failure presenting with persistent hypotension even after adequate fluid resuscitation and requiring vasopressor treatment. The third international consensus now defines sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to infection. In this new definition, sepsis is now upgraded to what we previously knew as severe sepsis. And this new definition includes a number of patients who were previously thought to be septic. On the other hand, septic shock is now defined as a subset of sepsis with circulatory and cellular or metabolic dysfunction associated with a higher risk of mortality. So before we head on to the summary of recommendations, I would like to go over the categorization of the quality of data for research. So we use the GRADE framework in categorizing and assessing the quality of evidence that we recommend or we show to the participants. For the quality of evidence, we have the high, moderate, low, and very low. With the high, further research is unlikely to change the confidence of the estimate of effect. The study designs usually include randomized controlled trials or the RCTs because these are the gold standard for research. For moderate, further research is likely to have an impact on the confidence of estimate of effect. So the study designs usually involve downgraded RCTs or upgraded observational studies. For low, further research is very likely to have the impact on the confidence estimate of effect as characterized by study designs with observational studies. And for very low, any estimate of effect is very uncertain. These involve case series or expert opinions. They could be lower despite the quality of evidence if the study quality has a poor quality of implementation of RCTs or you have inconsistent or difficulty of getting results. You also have a lower quality of evidence despite the categories if you have high probability of reporting bias. They could be higher, on the other hand, if you have a stronger association or a large magnitude effect with no plausible confounders, and a very large magnitude of effect with no major threats to validity, and the dose response gradient also. For the strength of recommendations to patients, clinicians, and policymakers, we also use the GRADE framework. So the strength of recommendation has two parts. So you have the strong strength of recommendation and the weak strength of recommendation. So for strong strength of recommendation, the benefits outweigh the harm. So there are no cost or access issues for the general population. For weak strength of evidence or recommendations, the best available evidence is very low to low quality, and the magnitude of benefits or risks is uncertain to closely balance the general population for applicable to a specific group. We now move on to the summary of recommendations and changes. So these are the summary and recommendations and changes for the Surviving Sepsis campaign of 2021. So the Surviving Sepsis campaign of 2021 outlined more than 90 recommendations for the management of sepsis compared to its 2016 campaign. It was also noted that the IDSA signed off on the 2016 recommendations because of the differences on the evidence regarding antibiotic therapy for sepsis and septic shock patients. And I'd like to highlight the second recommendation for the Surviving Sepsis campaign, which is they recommend against using QSOFA compared with the SIRS NEWS as a single screening tool for screening septic or sepsis or septic shock. They had a strong and moderate quality evidence with this one. So we'll just skim over the Surviving Sepsis campaign 2021 because I would like to highlight the Philippine guidelines or setting for management of sepsis and septic shock. Right. So for the summary of recommendations, we'll focus on the summary of recommendations for the Philippine CPG for sepsis and septic shock in adults 2020. This was released by the Philippine Society for Microbiology and Infectious Diseases. So the Philippine Clinical Practice Guidelines for Sepsis and Septic Shock 2020 aims to answer 70 health questions related to sepsis and septic shock, and provide recommendations accordingly. Although I picked provisions and or recommendations from these CPG that will be more applicable for us nurses. So we won't be going all 70 health questions. So question number 1, should we use sepsis 3 definition over the old sepsis definition? So the recommendation was they recommended the adoption of sepsis 3 definition for sepsis, which is life-threatening organ dysfunction caused by a dysregulated host response to infection. It has a strong recommendation with moderate quality of evidence. Before sepsis 3 definitions of sepsis and septic shock were published, the old definition of sepsis consisted of at least 2 criteria from the SIRS, plus infection whether suspected or proven. The term severe sepsis was previously defined as sepsis that was complicated by organ dysfunction, hypotension responsive to fluids, or signs of hyperperfusion. Similarly, the term septic shock used to refer sepsis with acute circulatory failure, particularly with a persistence of hypotension that was unresponsive to adequate fluid resuscitation and needing vasopressor treatment. The 2016 Sepsis 3 consensus revised the definition of sepsis to a life-threatening organ dysfunction caused by a dysregulated host response to infection, which was actually equivalent to the severe sepsis of old. The new definition makes the condition more specific as it removes those infections that are not life-threatening and present with at least 2 SIRS criteria, which could actually be just a normal response, host response to infection. The new sepsis definition has led to a formulation of the new clinical criteria for sepsis, again by 2016 Sepsis 3 consensus. Because there is no gold standard for it, the patient cases with infection but were really sick were used as proxy for septic patients as recently defined. For question number 2, should we use quick sequential organ failure assessment or the QSOFA over the systemic inflammatory response syndrome or SIRS as clinical criteria to identify patients with sepsis? So the recommendations were they recommend that QSOFA-based clinical criteria with at least 2 criteria in a patient suspected or proven infection be used to identify patients with sepsis. This has a strong recommendation and moderate quality of evidence. They also recommended that those with at least 2 SIRS criteria plus suspected or proven infection but not meeting the QSOFA more than 2 be observed for progression to sepsis. So this is the algorithm for the recommendation. So sepsis definition of a life-threatening infection prompted search for studies that looked into the ability of the QSOFA and SIRS to predict mortality among patients suspected for infection. So foreign and local studies consistently demonstrate higher sensitivity for SIRS, but better specificity of QSOFA in terms of number 1, predicting mortality, number 2, predicting organ dysfunction, and number 3, diagnosing sepsis. So there's the concern about the sensitivity and specificity of both SIRS and QSOFA. That's why it's recommended that they would use both. So question number 3, should the sequential organ failure assessment scoring based clinical criteria be used instead of SIRS based criteria in the diagnosis of sepsis in the ICU? The recommendation was they recommended the use of SOFA scoring-based clinical criteria instead of SIRS-based criteria in diagnosing sepsis in the ICU. The sequential organ failure assessment is a mortality prediction score that is based on the degree of dysfunction of the 6 organ systems. The SOFA score can be used to determine the level of organ dysfunction and the mortality risk in ICU patients. The scores can be used in several ways, including number 1, sorry about that, as individual scores for each organ to determine the progression of organ dysfunction, and number 2, as a sum of scores on a single ICU day, or number 3, as a sum of worst scores during the ICU stay. So number 4, should we use the sepsis 3 definition and clinical criteria to diagnose patients with septic shock? So the recommendations was they recommended the adoption of sepsis 3 definition of septic shock, which is a subset of sepsis underlying circulatory, cellular, and metabolic abnormalities that are profound enough to substantially increase mortality than sepsis alone. This has a strong recommendation in moderate quality of evidence. When serum lactate is available, they recommend that sepsis 3 clinical criteria of 1 hypotension requiring vasopressor to maintain a mean arterial pressure of 65 mmHg and a serum lactate of more than 2 mmol after adequate fluid resuscitation be used to identify patients with septic shock. This has a strong recommendation and moderate quality of evidence. And the next is when serum lactate is not available, we recommend that the previous clinical criteria of hypotension does not improve after fluid resuscitation, and number 2, needing vasopressor to maintain a mean arterial pressure of 65 mmHg be used to, at the minimum, to identify patients with septic shock. This is the algorithm for the said recommendation. So question number 5, should we routinely request blood cultures from patients suspected with sepsis or septic shock? So this is one of the more applicable, especially for the staff in the ICU or other institutions. This is a kind of a long-standing concern or issue if we should routinely request for blood cultures from patients with suspected with sepsis or septic shock. So the recommendation for this one that blood culture should be obtained before administering antibiotics to patients suspected with sepsis or septic shock. If doing so will not result in substantial delay of initiation of antibiotics. So they also noted that antibiotics should be administered within an hour of sepsis recognition, and blood culture should be complemented by appropriate cultures taken from the suspected focus of infection. So also for those hospitals or institutions that practice antimicrobial stewardship, for example, in our institution, we have an expedited release of restricted antimicrobials for sepsis or septic shock patients. The diagnosis of sepsis remains also a challenge due to a lack of unambiguous clinical criteria or laboratory features that would clearly identify patients with sepsis. So for most clinicians that rely on their clinical skills and experience to diagnose sepsis, and both clinical and microbiologic criteria are often used as a reference standard in diagnostic studies. Also, in some scenarios, bacterial cultures are still considered as reference standard for detection of infection. However, the low pathogen yield as well as the waiting time for results continue to be a stumbling block in efficient and accurate diagnosis of sepsis. So for question number 10, in patients with sepsis or septic shock, should we initiate fluid resuscitation within an hour of sepsis recognition? So the recommendation was they recommend that fluid resuscitation be initiated immediately upon recognition of sepsis or septic shock. This has a strong recommendation and moderate quality of evidence. Review of literatures revealed that most studies bundle the pre-specified timing of fluid administration together with other interventions, such as available studies on a single component therapy were assessed to be of low to moderate quality. For question number 11, in patients with sepsis or septic shock, should we give a 30 milligram per kilogram intravenous fluid bolus for initial fluid resuscitation? So the recommendation is they suggested that initial resuscitation of 30 milliliters per kilograms of intravenous fluids to patients with sepsis-induced hyperperfusion. This has a conditional recommendation with low quality of evidence. So they remarked as well that patients with sepsis-induced hypoperfusion include those who are hypotensive or have lactate levels of more than 4 mmol per liter. For question number 36, they actually divided these into 3 subsections. So in patients with sepsis-induced acquired respiratory distress syndromes, or ARDS, should we use lung protective ventilation strategies? The 36.1 also asked that in patients with sepsis-induced ARDS, should we use low tidal volume ventilation? For 36.2, in patients with sepsis-induced ARDS on mechanical ventilation, should we use high versus low positive and end expiratory pressure strategy, or the PEEP strategy? For 36.3, in patients with sepsis-induced ARDS who are mechanically ventilated, should we use plateau pressures less than 30 mmHg? So recommendations is that they recommended to bundle the lung protective ventilation strategy in ventilating patients with sepsis-induced ARDS. So the bundles include the following. They recommended use of low tidal volume such as 6 ml per kilograms using predicted body weight, or the PBW. This has a strong recommendation with a high quality of evidence. So they remark that predicted body weight is calculated as 50 plus 0.91 centimeters of height for males and 45 plus 0.91 centimeters of height for females. They also recommended providing PEEP as guided by the PEEP FiO2 table of the ARDS net and the alveoli studies of 2004 to target the partial oxygen between 55 and 80 millimeter mercury to, or peripheral O2 saturation of 85 to 95%. So I have a table at the end of this showing the ARDS PEEP FiO2 tables. They also recommended targeting a plateau pressure of less than 30 cm of water. So plateau pressure should be measured or recorded at least 1 minute after changing of PEEP or tidal volume taken in a relaxed patient. A plateau pressure recorded of 0.5 inspiratory pause in a relaxed patient should be considered. So these are the tables for the PEEP FiO2. There are no large RCTs, just to note, that specifically investigate the effects of mechanical ventilation on sepsis-induced ARDS. Most of the studies that exist look into the benefit of lung protective strategies, which include giving low tidal volume, high PEEP, and limiting plateau pressure during ventilation of ARDS. RCTs are needed to further evaluate such potential strategy. So for question number 50, in adult patients with sepsis, should we use hemoperfusion or other blood purification techniques? So they did not recommend at this time any blood purification modalities such as hemoperfusion, plasmapheresis, or hemofiltration for patients with sepsis or septic shock. So trials from Asia have released promising results. However, the recently published study conducted in 55 tertiary hospitals in US and Canada called the Euphrates trial yielded inconclusive results. So for number 61, question number 61, in adult patients with sepsis or septic shock who can be fed enterally, should we use enteral feeding versus early total parenteral nutrition, the TPN? So the recommendation was they recommended the use of enteral nutrition in patients with sepsis who are hemodynamically stable and can be fed enterally. So malnutrition is defined as a state of resulting from lack of intake or uptake of nutrition that leads to altered body composition. So this means a decreased fat-free mass and body cell mass, leading to diminished physical and mental function and impaired clinical outcome from the disease. Malnutrition can alter the patient's clinical course and lead to a significant morbidity and mortality. Due to increased metabolic needs in septic patients, addressing nutrition has the potential to improve survival. So enteral nutrition refers to a nutrition strategy or a nutrition therapy given by an enteral tube or stone. So the parenteral nutrition is a type of nutrition provided through an intravenous administration of nutrients such as amino acids, glucose, lipids, electrolytes, vitamins, and trace elements through a central venous line or peripheral intravenous line. So overall studies, earlier studies did not show a clear benefit for enteral nutrition over the parenteral nutrition. And a large multicenter study actually done in 34 critical care units in the US or the UK showed that there was no difference in a all-cause 30-day mortality between the two groups, that the PN was equated to higher mean. For question number 62, in adult patients with sepsis or septic shock who can be fed enterally, should we give early enteral feeding versus delayed enteral feeding? So the suggestion is they suggest the initiation of early enteral feeding within 24 to 48 hours in adult patients with sepsis or septic shock. So early enteral feeding is the initiation of feeding within the first 24 to 48 hours of admission, of ICU admission or injury. A meta-analysis study that was done in 2009 of 6 trials involving 234 critically ill patients showed that initiation of early enteral feeding is associated with a significant reduction in mortality and incidence of pneumonia. For question number 63, in adult patients with sepsis or septic shock who can be fed enterally, should we give supplemental parenteral nutrition on top of enteral feeding? So the suggestion is they suggested against routine supplemental parenteral nutrition on top of enteral nutrition in patients with sepsis or septic shock. For patients who are not able to meet their requirements fully through enteral route for a week, they suggested that supplemental parenteral nutrition to increase caloric and protein delivery. So studies on nutrition have shown that negative energy balance can have deleterious effects. However, enteral feeding has limitations in terms of patient tolerance and risk for aspiration. Hence, we could explore the evidence for a combination of enteral and parenteral nutrition or supplemental parenteral nutrition in septic patients. For question number 64, in adult patients with sepsis who are fed enterally, should we give prokinetic agents to prevent feeding intolerance? So they do not recommend the use of prokinetics for prevention and feeding intolerance in patients with sepsis or septic shock. No. And for question number 65, in adult patients with sepsis or septic shock who are fed enterally, should we give prokinetic agents to manage or treat feeding intolerance? So they suggest the use of prokinetics to treat feeding intolerance in patients with sepsis or septic shock. This has a conditional recommendation with low quality of evidence. For question number 66, in adult patients with sepsis who have enteral tube, should we use post-pyloric tube feeding versus gastric tube feeding? So they recommend that the enteral nutrition be initiated via the gastric route. Post-pyloric feeding may be considered as well in patients with feeding intolerance and not improved with prokinetics. So feeding intolerance due to delayed gastric emptying had been shown to occur in critically ill patients. So this may lead to reflux and put a patient at risk for aspiration pneumonia. In other conditions such as history of previous aspiration or presence of anatomic abnormalities or of the GI tract may also increase the risk for aspiration. For patients with delayed gastric emptying, post-pyloric feeding may be beneficial due to its obvious advantage of bypassing the stomach and deliver nutrition to the small bowel, which has better absorbative capacity and motility. For question number 67, in adult patients with sepsis, should we follow a standard feeding protocol? So they suggested the implementation of a standard feeding protocol to improve delivery of target calories and protein to patients with sepsis and septic shock. So this is a sample algorithm for the said recommendation. So a feeding protocol refers to an algorithm enabling the bedside nurse to start monitor, and adjust the delivery of enteral tube feedings to patients not capable of oral food intake. So this benefits the enteral nutrition are often faced with challenges of actual delivery. Feeding protocols have been proposed to initiate an increased nutrient delivery for patients since calorie and protein deficits are related to adverse outcomes. Clinicians often overlook nutritional management in patients with sepsis or septic shock. Hence, a protocol may provide an action to manage feeding issues. It is also recommended that enteral feeding protocols be designed and implemented to increase overall percentage of goal calories provided. So for the best practices in the local setting, in our institution, we did a study. We did several studies on regarding uh, management and identification of sepsis and septic shock. We also did a study on the effectiveness of following a rigid or robust protocols regarding the identification and management of sepsis. So for the first study, this was a prospective cohort study of the quick sequential organ failure assessment, or the QSOFA score, versus the systemic inflammatory response syndrome, the SIRS criteria in determination and prognostication of sepsis in a Philippine tertiary hospital. So this was done by our colleagues at the medical city. So for the methods, they to compare the 295 adult patients in emergency room with suspected infection were included in the study, simultaneously determined their QSOFA score and SIRS criteria. So 3 infection specialists adjudicated the presence of sepsis, and outcomes within the first 48 hours were acquired. Sensitivity, specificity, positive predictive and negative predictive values for QSOFA and SIRS were computed using constructed confusion matrices, and overall predictive accuracy was measured by the area under receiver operating characteristic, or the OROC curve. So the data from this showed that the QSOFA is a good indicator or predictor of in-hospital mortality by identifying high-risk patients requiring more aggressive management and higher level of monitoring, even when additional laboratory or diagnostic tests are not available, similar to most studies on QSOFA. So having a QSOFA of equal to or more than 2 confers a 12-fold higher risk of sepsis and hence a higher risk of mortality and morbidity. The study concluded that the QSOFA score was a more accurate predictor of sepsis and a reliable predictor of in-hospital mortality, but should not be used as a sepsis screening tool due to low sensitivity. So it coincided with the recommendations of the Surviving Sepsis campaign of 2021 and the Philippine Clinical Practice Guidelines for sepsis and septic shock in adults. It was recommended also that the SIRS criteria be maintained as a screening tool to use the QSOFA score concurrently for time management. So in the Philippines, the QSOFA score is underutilized and sepsis is diagnosed by using the SIRS criteria. So we actually advocate the use of SIRS criteria as the preferred screening tool for sepsis while simultaneously using the QSOFA score to prognosticate, since the former is a more sensitive test, while the latter is the more specific for organ dysfunction and mortality. So the concern with the specificity and the sensitivity of both the QSOFA and the SIRS can be addressed by using both tools concurrently with each other. The second study that was done in our institution is a 10-year longitudinal analysis of both protocol-based sepsis management in the Philippine tertiary ICU. Again, was done by our colleagues at the Medical City ICU and the Medical City Sepsis Alert Group. So the objective of the study was to compare the outcomes of sepsis management using a protocol-based therapy versus a non-protocolized care. So we actually did a study if the protocols in place that we have at the medical city were effective in sepsis or in sepsis management. So the methods, the study was a retrospective cohort of patients in the medical city, a 500-bed tertiary teaching hospital in Pasig City, Philippines. The TMC ICU is an 18-bed mixed-use unit that follows a semi-closed model of care. So all medical records of patients 19 years old and above who were admitted in the ICU between October 2007 and September 2017 with a discharge diagnosis that included severe sepsis and septic shock were reviewed. Criteria for inclusion as follows. So number one, you must have a suspected infection. Number two, at least two of the systemic, the SIRS criteria, and three, signs of end organ damage. So patients who were not admitted in the ICU and those with requested limitations to intensive care, such as a DNR status, prior to immediately upon ICU admission, were excluded. So this has 760 patients in the protocol-based care group versus 190 in the non-protocolized care group. So the protocolized management was associated with lower hospital mortality and the ICU mortality. And the study concluded that the protocol-based management was associated with sustained improvements in the survival of sepsis patients over 10 years in the hospital setting after a run-in period of 1 year. So hospital and unit level interventions may have measurable impacts on the efficacy of sepsis clinical pathway. So we actually recommend that institutions employ a clinical pathway for sepsis. So this is the data that shows the risk or the observed mortality for the blue series, or the blue line here shows the observed mortality of patients with sepsis and septic shock. The red series is the predicted mortality, while the yellow and green series are the lower and higher confidence interval of control limits. So implementation of institutional changes and events are also marked here. So letter A, so this one at the top here, was the pilot study of sepsis alert pathway. This was done in 2007. B is the hospital-wide launch of the first version of the sepsis alert pathway. It was done in May 2008. For the C is the actual start of fellowship in critical care medicine, which was done April 2010. For the D is the implementation of the rapid response system, done October of the same year. E is the implementation of the radio frequency identification in ICU, done January of 2011. For the F, this was the start of residency in emergency medicine. And G was the purchase of ultrasound machine dedicated to the ICU. The H was the management directing regarding pathway activation, and the pathway version implementation differentiated. The blue was the first, the blue column here was the version 1 of our sepsis pathway. The yellow column is the version 2 and the red is the version 3. We can see here that there is a drop in mortality rates of patients if you have a robust and robust pathway for sepsis management and guidelines. So this was the hospital policy that we have for sepsis care management. So this was the latest version of our policy. So it also had an instruction for sepsis pathway activation. So as long as they meet these criteria, the sepsis pathway activation is automatically activated. These were also the forms that we use for sepsis management and the clinical pathway for sepsis. So implementation is not without challenges for sepsis management, especially here in the Philippines. So the challenges in implementation is number one, a lack of robust institutional policy for sepsis detection. We also have an overburdened healthcare staff and system. And of course, lack of research as stated by the WHO and under-supported institutions. We also have a challenge in the lack of staff training for sepsis detection and management, and varying professional findings regarding recommendations for sepsis screening. Uh, we also have challenges in poor infection prevention and control programs in some institutions here in the Philippines, and most institutions do not have antimicrobial stewardship practices. So to end my presentation, I would like to leave a quote from the CDC. So the CDC says that anyone can get an infection and almost any infection can lead to sepsis. So thank you.
All right. Thank you, Sir Phil, for that very informative presentation on your topic. So do we have any questions from our audiences? So now we will be entertaining questions. Just type in our chat box. All right, we are waiting for your questions. All right, Sir Phil. There is a question here. How do you handle situations where sepsis protocols are in place but difficult to fully implement due to some reasons, particularly staffing or there is a resource constraints?
Thank you for that question, ma'am. So in our in my experience, we handle um, those kinds of challenges in our institution by actually continuously training the people that are involved or in the front lines, especially for in the emergency room or in the ICU, because we cannot ignore that there is really a high turnover of staff, especially in our hospitals nowadays. So the only way to mitigate is for all the staff to be learned on how to detect, on how to assess, uh, or how to manage cases such as sepsis or septic shock. In that way, even if there is a high turnover rate for a institution, uh, the staff would still the remaining staff would still know how to handle, manage, or detect uh, cases of sepsis or septic shock.
All
Also,
right.
I would like to reiterate the role of infection control in the fight against sepsis. Because if there is lack of infection control, good infection control practices in an institution, as we saw in the earlier slides about the epidemiology of sepsis, it's 1 in 4 people who get sepsis inside the hospitals. So we need to constantly educate the staff and the patients and visitors regarding sepsis.
All right. So there should be a constant training. So in line with that, we have a question here in our chat box from Nathan. Are there any continuous training for healthcare workers regarding sepsis or septic shock in order to reduce the incidents?
In our institution, yes, the sepsis alert group or the sepsis committee. We have a sepsis committee in the institution, in the sepsis alert group. Both of the groups are very active in educating, and they actually meet every once a month just to check on the status of sepsis cases in patients in the institution.
All right. Thank you, Sir Phil. We also have another question here in the Q&A chat box. How does sepsis progress into septic shock?
Primarily, it progresses into septic shock if there is a poor infection control practices in hospitals. Because the one good example that I always use is hand washing or hand hygiene. So uh, a, a deed as simple as hand washing can prevent uh, infections for patients and prevent them from progressing to sepsis to septic shock on patients. Also, early detection and management is key or essential without delays. That's why there was a concern about giving antimicrobials because it sometimes uh, has delays, especially when you practice antimicrobial stewardship in the institution. There might be delays in dispensing uh, uh, restricted antimicrobial. So what we did is we actually exclude the first instance of an antimicrobial use for sepsis and septic shock patients so as to expedite the dispensing of those medications.
Okay, all right. We also have another question from Ma'am Lilibet Paredes. Some of our patients have financial constraints that cannot afford to have blood culture and sensitivity. Some doctors will order to start antibiotics even with no blood CS. What is your stand on this matter?
Um, I believe there is a recommendation regarding the use of broad spectrum antimicrobials, but on our institution, uh, we do not really recommend that they give antimicrobials without having a blood culture and sensitivity. However, if there is a need to start the antimicrobials without blood, because it's really a matter of life and death situation. If they cannot have a blood culture and sensitivity without giving antimicrobials, then uh, that would be left to the clinical judgment of the physician.
All right, I think we can cater one more questions. There are a lot of questions. And if you can stay for a bit, Sir Phil, to answer those questions. Yeah, so we will be catering one more question. So we have from anonymous attendee, good day. May I ask what role does nurse playing in differentiating early sepsis from other common febrile illnesses in the Philippines?
The role of nurses are essential in identifying the signs and symptoms of sepsis, especially when you have the training and you have the knowledge to do so. I believe that the nurses, especially in the ICU and the ER, they are always we are always with the patients, so we would know if or we must know if what to look for in terms of identifying sepsis or septic shock. So being with the patients constantly is already a key to um, responding to sepsis or septic shock.
Okay, all right, Sir Phil, we will not hold you long. But if you can just have give us ample time for you to be able also to answer those questions in the chat box. Right? So let's proceed for to our giving of certificate. So let me read the citation. Critical Care Nurse Association of the Philippines, in partnership with the World Federation of Critical Care Nurses, awards this certificate of appreciation to Sir Fortune Charles Phil V. De Lara, RN, IPCC, as our speaker during this webinar, World Sepsis Day, Think Globally, Act Locally, Combating Sepsis Together, conducted this September 13, 2025, 8:30 to 12 noon Philippine time, signed by the President of the CCNAPI, Maria Isabelita C. Rogado, MAN, RN, and the President of the WFCCN, Kathleen Volman, MSN, RN, CCNS, FCCM, FCNS, FAAN. A round of applause, please, for Sir Phil De Lara. Once again, thank you, Sir Phil, for sharing your knowledge on localizing sepsis care in the Philippines. Your expertise in infection prevention and control has provided us with practical strategies for improving sepsis care in our local setting. Thank you once again and have a great day. So now, without further ado, let us proceed to our next topic, equally exciting and equally interesting topic. So our second topic would be the world's fight against sepsis. A look at management and prevention strategies. Ladies and gentlemen, nurses all around the world, let us all welcome Suman Shrestha, MBE, MCC, RN, MFICM. Good morning, Sir Suman. The stage is yours.
Good morning, Wella. Can you hear me okay, yeah?
Yes, loud and clear.
Brilliant. Let me just share my screen and then we can proceed. Okay, can you see my screen?
Yes, Suman, we can see your screen.
Brilliant. Thank you very much, Wella. Thank you very much. It's an absolutely honor and pleasure to be here today on World Sepsis Day to be speaking to you on sepsis here. Before I start, I'd just like to kind of remember all the patients and their families who's been affected by sepsis. I think it's a quite a tough condition to go through, and even when the patients actually survive sepsis, they tend to have long-term conditions and so on. So our thoughts and prayers for all the families and patients affected by sepsis on this. And also, you know, I'd just like to thank all the healthcare professionals as well who spend day in, day out on you know, helping patients with sepsis. My name is Suman Shrestha, and I am a consultant nurse in intensive care in the UK hospital, and I'm also a professional lead for critical care at the Royal College of Nursing in the UK, and I work in 2 hospitals in intensive care here in the UK. There's a 700 bedded hospitals, and we have 16 intensive care beds in each of the hospitals that I work in. And one of my roles is professional lead for critical care at the Royal College of Nursing, which is one of the which is the world's actually biggest professional and nursing trade union in the world. And we support our members, but also we develop resources and training materials and policies for our staff as well. But we also influence and lobby and government and other stakeholders on matters relating to nursing and healthcare. What I would like to do next hour or so is just to talk about sepsis in a sort of broad sense. I'll give you a broad overview of what sepsis is. We'll share some data around sepsis, but most importantly, we talk about the management strategy for sepsis and just provide you some evidence base in the background, and also some of the prevention strategies that we want to use in order to manage patients with sepsis. Well, sepsis is a global health crisis. The reason why we say this is that the World Sepsis Day data shows that 47 to 50 million people are actually affected by sepsis every year, and around 11 million people die from it. Around the world, someone somewhere dies every 3 seconds due to sepsis. So it is a huge, huge issue. 1 in 5 deaths worldwide is associated with sepsis. And those who survive actually can develop long-term problems, which can be actually quite problematic for the patients and their families and relatives too. This is why World Health Organization back in 2017 actually put sepsis as one of the global priorities. And a lot of work has been done in order to address the issue. But despite that, we know that, although 20% of deaths globally is associated with sepsis, not all the countries that actually have policies and procedures in place to manage sepsis. Fewer than 10% of the countries actually have sepsis protocols for timely and effective treatment of children and adults. When you look at the data is quite mixed, and we don't really have a true understanding in terms of data about how actually sepsis affects our global population. And the occurrence of sepsis varies between the countries as well, so as the mortality. So there's a huge gap on the data for what data around sepsis itself. But there are some good news as well from some of the data that we have seen. There are some good news. So this was published a couple of years ago, and which actually indicated, we looked at the data from sepsis between 1990 to 2017, and which indicated that actually incidence of sepsis has fallen by 37%. And this might be because of all the education, training, and resources that we put in over the years around managing sepsis. And mortality has also decreased by about 52%. So this is a good news. Here in the UK, where I practice, sepsis still is one of the leading causes of hospital admissions. There are about 900,000 admissions happens every year in the UK relating to sepsis, and about 66,000 people in the UK die of sepsis. And it is quite costly as well. It's about £2 billion, British pounds, actually spent every year treating sepsis just in England alone. And we know from some of the economic studies that, for the wider economy, it's actually even more burdensome. So it's about, in the UK, it is estimated that 15.6 billion is actually spent each year on managing sepsis, because not only the burden is on the healthcare system, but actually patients who develop sepsis rely on benefit systems, or they might develop further medical conditions. They might not be able to go back to work and contribute to the economy, and that can actually create more burden for the government and the society. So what is sepsis? In simple terms, sepsis is a life-threatening reaction to an infection. It happens when your immune system overreacts to infection and starts to damage your own body's own tissues and organs. So that's what sepsis is. But we do have an academic sort of definition of sepsis, which was published back in 2016. We used to call it a new sepsis definition, but actually it's been more than 10 years ago now. Nearly 10 years ago. But the group from around the world, the experts actually got together and defined sepsis back then. And the definition is this: sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. Now, what that means is that, let me just break it down for you. So in order to diagnose sepsis, the first thing you need is infection. If there is no infection, if the cause of patient deterioration is not related to infection, then it is not sepsis. But we don't always know when the reason for the patient deterioration is infection. Sometimes we might have a strong suspicion of infection, and that is good enough. But infection has to be part of the process, okay, in order for us to diagnose sepsis. And now we all get infection at some times, and our body responds differently to infection. In some patients, we don't really know why. Their immune system goes into overdrive. It could be a genetic factor. We don't really fully understand, but they respond differently. This is what we call sort of dysregulated host response. And that then leads to acute organ dysfunction, which can be threat to life. And the patient might demonstrate signs and symptoms, so low blood pressure, desaturation, and so on. And that is life-threatening, and that's what sepsis is. It's a life-threatening reaction to an infection. And when they revised the definition of sepsis, they also looked at the clinical criteria for septic shock too. Now, in old days, we used to think that somebody has got infection and they are hypotensive, they've got low blood pressure, then we used to think that is septic shock. But actually that concept has now changed. There are actually two clinical criteria that we need to look at in order to diagnose septic shock. The first one is hypotension. So that is when someone's blood pressure is less than 65 millimeters of mercury, that's mean arterial pressure, that is, and requiring vasopressors. Okay, so that's the kind of first clinical criteria. And the second criteria is around lactate. So their lactate is greater than 2, and that's despite adequate fluid sustain. So when you have these two clinical, you need these two clinical criteria in order to diagnose septic shock. Now, when you look at the sources leading to sepsis, pneumonia tends to be the leading cause. And this was from the study that we've done in the UK, an NCPORT report. But actually, even if you look at the wider literature, chest infection, pneumonia tends to be the #1 reason for leading to sepsis, followed by, UTI, a urinary tract infection, and abdominal infections, and soft skin tissue infection, like cellulitis or sometimes necrotizing fasciitis. So these are the kind of leading causes of infection leading to sepsis. And sepsis affects all ages, from babies, young people to fit and well individual. For example, the girl in the middle who's a triathlete, who actually developed infection and developed sepsis, and sadly died a few years ago. But also rich and famous people, get sepsis. So actually sepsis affects everyone. And this study actually proves this point, that when you look at the hospital admission, number of admission in the top bar here, shows that the admission related to sepsis happens in all age spectrum, okay, all age spectrum. But if you look at the hospital mortality, the 77% of the death actually occurs in our elderly population, who are 75 years and over. So our elderly patients are the most vulnerable one, who has got potential to die as a result of sepsis. But there are also other risk factors associated with sepsis. So I just mentioned elderly patients, and patients who are frail, malnourished, are at high risk. But also those patients who have long-term conditions like liver failure, lung disease, kidney disease, diabetes, they're at risk of developing sepsis. Patients with mental health and learning disability, that I think there's a focus shift on looking at those patient groups, because quite often they are not able to advocate for themselves in order to seek healthcare services. And as a result of that, by the time they present at the health services, it might be too late. So they are also at high risk of dying as a result of sepsis. Patients with impaired immune systems, those who are in chemotherapy, immunotherapies, and so on, at risk of developing sepsis, developing infection, and dying from this as well. In intensive care, patients with ET tubes, catheters, CVCs, PICC lines, they're all risk of getting infection from patients at risk of getting infection from those and developing sepsis. Post-operative care, patients just following surgery through sort of wound infections, patients with pregnant, postpartum at risk, patients with wounds and burns, and also post-organ transplant patients who might be on sort of anti-rejection drugs and so on, are at risk of developing infection and developing complications such as sepsis. Now, when we look at the sepsis, we need to understand the features of possible infection. So when we look at sepsis, we need to look at, like any deteriorating patient, the good structure to look at is airway, breathing, circulation, disability, and exposure. And these are the suggestive sort of signs and symptoms of sepsis. As you can see, from airway and breathing point of view, patient might have an increased respiratory rate, they might be short of breath, they might have low oxygen saturation, and so on. From circulation point of view, their pulse might be high, they might be tachycardic, but as the time goes on and when the patient actually deteriorates, their pulse might be, actually thready and slow. They can be hypertensive, they might have cool peripheries. As you can see, there's loads of signs and symptoms of sepsis. And quite often these signs and symptoms are quite generic as well. And this is why sepsis can be quite difficult actually to recognize in the initial stages. And when you compare sepsis with other medical conditions, like, for example, myocardial infarction, somebody's having a heart attack, the presentation can be reasonably straightforward. They might have chest pain, right? In a populational risk, we know that, middle-aged, Asian man, for example, if he complains of chest pain, you wouldn't think anything of other than probably MI, right? And you would do a bedside test, like ECGs and so on we can do, but we can also do something like troponin, we can do echoes, and we can do imaging like angiogram. So diagnosis is relatively easy, and similar with the stroke or fracture. But when you compare those leading causes of death with sepsis, the presentation can be non-specific, just like I've shown you in the previous slide, that the patient can present with a whole range of signs and symptoms in sepsis. Population at risk, all age group is at risk of developing sepsis, again, from the slides that I showed you a couple of slides earlier. Do we have a bedside test that we can do to diagnose sepsis? We currently don't. There are some diagnostic tools under development, but we don't really have a robust bedside test that we can do. So quite often the diagnosis relies on clinical judgment. Do we have imaging? Yes, of course, we have like CT scans we can do x-rays and so on, but there's nothing sort of specific thing that we can do. So diagnosis can be quite difficult, particularly in the early stages of sepsis. So when to suspect sepsis? Well, we should think, could it be sepsis when the patient deteriorates or when they show signs and symptoms that indicate possible infection? Any indication of clinical concern, such as new onset of abnormal behavior, patients become confused. That's not like them usually, right? If there is a new clinical concerns regarding their circulation, they're hypotensive, they're tachycardic, or there's a respiratory concerns and their oxygen saturations drop, the respiratory rate has gone up, so on. We need to pay particular attention to concerns that are expressed by patients themselves, but also importantly, their family and carers, because quite often, patients, family, and friends, they know the best, okay, about their loved ones. So we should also always take their points really seriously when they're expressing concerns. We need to consider that, patients of sepsis may not have, specific signs and symptoms. They might just present with very, very non-specific, signs and symptoms. They might just say that they're feeling unwell for the last week or so, and that sort of thing. And sometimes patients feel unwell and they may or may not have temperature. With sepsis, not all the patients actually generate temperature. So temperature can be sometimes misleading. So we often see, or hear in clinical practice that, do blood cultures when the patients actually spike temperature and so on. But actually, quite a lot of elderly patients, because of their immune system, they might not actually generate temperature. They might not generate pyrexia. Okay, so not all the patients with sepsis have temperature. Now, if patient has a temperature, if they're pyrexial, yes, they might have infection and they might be septic, but if they don't have a temperature, doesn't mean that they are not septic. I think that's the key thing to remember. Antimicrobials seems to be the strategy for managing sepsis. So it is the treatment of managing sepsis. But over the course of the years, obviously through lots of investment on training, education, and awareness, we're actually seeing increased use of antibiotics. And these are the data from England here, and we have seen a spike in the use of antibiotics. Now, problem with this is that I'm going to come to the problem with this, but we have also seen the spike in the use of antibiotics globally as well. And this is the data from sort of low and middle income countries. We have seen a massive spike over the last couple of decades on increased use of antibiotics. And this could be because of all the sepsis awareness and awareness of how we actually treat infection and so on. But the problem is that with the increased use of antibiotics, we have also got this new challenge in our hands, which is the antibiotic resistance. And it is becoming a global concern. And in the UK alone, so we are now seeing a gradual rise in antibiotic resistance. And there is also antibiotic resistant death associated with this as well. So we are seeing a gradually increase. And for some reason, that Asian British ethnic group had actually almost double the proportion of antibiotic resistant infections. We don't really fully understand this, but the data is indicating that way. So we've got another problem in our hand. And this is a global issue. It is estimated that about 3,500 people die every day now with antibiotic resistance. So this is where one of our chief medical officers, who've actually put a massive warning last year saying that this is a huge, huge problem and it could be bigger than the pandemic. And so we need to really be serious about how we use antibiotics to manage infection. And the data around the timeliness of antibiotics therapies is also quite interesting. So this is one of the systematic review that's done and really actually did not find true association between early antibiotics delivery and patient outcome. So this is why, I think the way we give antibiotics in sepsis has changed. You're probably familiar with the Surviving Sepsis Campaign International Guidelines that was published back in 2021, and I think it's currently been revised and I think due to be published in the next couple of months, I believe. They were the first one to actually recommend the antibiotics uses and timing slightly differently to traditional recommendation of within an hour. So this is one of the key messages I'd like to give you today on my session, that antibiotics timing is really, really important. Now, if the patient is presented with infection and sepsis is definite, right? Please don't delay giving patient antibiotics. We should give antibiotics as soon as possible, ideally within an hour. Yeah, when you know that the patient has got sepsis and you know that it is due to infection, right? But when sepsis is possible, you're not 100% sure that the deterioration is actually sepsis. It's all the signs and symptoms, clinical history leads to thinking that it might be infection, but you're not 100% sure. But if the patient is in a shock state, then yes, give antibiotics within an hour, okay? Because patient is in a shock state. But if the patient is not in a shock state, right, they're relatively holding their, the blood pressure is actually holding, then what we should be doing is actually doing a rapid assessment of patient and doing some further investigation on actually trying to find out the cause of deterioration. Is it actually infection, right? So it might be doing tests, CT scan, chest X-ray, whatever that you would like to do, or even senior review, that we should be doing that. And we should be administering antibiotics to these group of patients within 3 hours. In other words, not rushing in to give antibiotics, but have a clear diagnosis before you do that in order to maintain antibiotic stewardship. So in clinical practice, how do we then put this into clinical practice? So in order to do that, we actually published in the UK this statement on initial antimicrobial treatment of sepsis. I'm quite happy to share the links to this in the chat after the session, but I thoroughly recommend you read these two documents. They're really, really useful. And there are loads of resources. There are loads of good references as well at the back, particularly the first document that I've shown you. And I've been privileged position to be part of the working group on this. And we've also published a NICE guideline, which is the National Institute of Health and Clinical Excellence guideline on management of sepsis. What is now last year, but again, this has been currently revised. So we have published these documents to actually then imply those principles that I've just talked about in clinical practice. So what do we do in clinical practice then? So when we assess patients, we take his patient history, do a physical examinations, and what we're now recommending in our healthcare settings is using NEWS2 score. That's National Early Warning Score. And National Early Warning Score is now quite well known. This was devised by the Royal College of Physicians in the UK, and it basically looks at these sort of 6 parameters: your oxygen saturation, whether patients are receiving air or oxygen, their blood pressure, their pulse, their conscious level, and their temperature. And then you score them according to where the patient is, and you come up with the number. If the number is 7, that is, patients are high risk of deterioration, requires urgent emergency sort of treatment strategies. Patient would need to immediate review. If there is 4 to 5, that they are like a moderate risk. If they're 1 to 4, then low risk, and 0 is very, very low risk. And according to the scores, you'll have a clinical response as well. And this National Early Warning Score is now implemented in a lot of healthcare settings. And now we use this to actually detect or monitor patients in hospitals and even in the community too. NEWS2 score has been found to be really reliable in terms of detecting sepsis, and this is one of the studies that actually shows that NEWS2 scores outperforms even better than the QSOFA that in order to detect patients with infection and sepsis. And the reason behind that is if you compare NEWS2 with the SIRS criteria or the QSOFA, so look at the SIRS criteria, it only looks at 4 variables. QSOFA only looks at 3 variables: your blood pressure, your respiratory rate, and your mental status. Whereas National Early Warning Score looks at 7 variables: your temperature, your heart rate, the blood pressure, the respiratory rate, and mental health, mental status as well. So this is why I think NEWS2 score is far more superior to the others. So what does it look like in clinical practice? So this is the guidance that we use in the UK. And so we do a NEWS2 scores on our patients. As I mentioned, if somebody's score is 7 or greater than 7, they're at high risk. 5 to 6 is a moderate risk. 1 to 4 is low, and 0 is very low, risk. And in terms of response, doesn't really matter, whether you are deteriorating as a result of infection or any other medical conditions. The clinical response is actually same. Okay, so if the patient is NEWS score is 7 or greater than 7, then patient should be seen immediately within 30 minutes. And the treatment strategy should be started within an hour. But now what we're urging healthcare professionals to do is that when the patient deteriorates, is ask this question: what's the likelihood of this clinical deterioration? Is it because of infection, right? So we look at the clinical likelihood of infection. And if the clinical likelihood of infection is not due to, it's not due to infection, then, it is not sepsis, okay? So you just then treat patients with whatever the underlying medical signs and symptoms are. But if it's possible, but if your patient is, at low risk, their NEWS score is, less than 4, then we have a 6-hour window to actually do a little bit of investigation, get maybe a senior review, send bloods, do X-rays, and so on. Okay. If their NEWS score is between 5 and 6, they're classed as moderate risk, then we have 3-hour window to actually do microbiology test, again, get a senior review, and so on. But if the patient's NEWS score is 7 and greater, which are their high risk of deterioration, then this is the group of patients that we need to give antibiotics within an hour. Okay, so this is the guidance that's been sort of published through the Academy of Medical Royal Colleges, but also that's reflected on a NICE guideline too. So that is about timing of antibiotics. But how do we give antibiotics? It's also been a topic of discussion lately, and you might have come across this trial called the BLING-3, a randomized control trial. This was again published last year, which looked at the continuous infusion of antimicrobials versus intermittent infusion. And in fact, it didn't, the primary outcome, well, it didn't really demonstrate any all-cause mortality, was pretty much the same, but one of the things that highlighted was that the clinical cure was higher in the continuous group. Okay, so continuous infusion group had a sort of higher rate of sort of clinical cure. And then the meta-analysis also, when you put all the studies together, comparing the intermittent versus the continuous infusion, it's actually majority of the studies actually are in favor of continuous infusion. So this has actually triggered some debate around how we actually administer antibiotics to our patients. Of course, continuous infusion of antibiotics comes with a number of challenges. You need pumps, you need obviously a dedicated line, and it might hamper patients' rehabilitation because they're attached to pumps and infusions and so on. So it comes with the challenges, but the evidence is actually leaning towards the continuous infusion, and this might need a wider discussions and review moving forward. We also need a good biomarkers in sepsis in order to detect infection and manage sepsis. At the moment, we just don't have any good diagnostic tools to actually detect infection and sepsis. But again, ADAPT Sepsis study was published last year, which actually looking at the procalcitonin. And this actually again found that there is significant safe reduction in total antibiotics use when you actually manage patients using procalcitonin. Okay, the number of days patients requiring antibiotics, antimicrobials, was actually less when you use procalcitonin versus CRP, which is a traditional way of actually monitoring patients' infection. So this study is going to be quite good in terms of antimicrobial stewardship. But managing patients with sepsis is not just about antibiotics. We also need to look at the wider management too. So looking at the airway and breathing, and one of the things is that giving patients oxygen, and oxygen saturation target should be between 94 and 96%. But those patients who are at risk of hypercapnic respiratory failure, those are patients who got COPD, we should aim for saturation between 88 to 92%. And so the recommendation for oxygen saturation between 94 to 96% comes from this study, which actually showed that that liver oxygen therapy increases mortality without improving other patient outcomes. So actually giving patients too much oxygen is actually quite harmful. So 94 to 96% is probably enough for patients. We also need lactate when we actually managing patient with who has deteriorated, not just from sepsis, but whole wide range of deterioration. As you will know, in intensive care, lactate is one of the key thing that we look at, and it is a really good indicator of how sick the patient is. And we know that if a patient's lactate is over 4 and they are hypotensive, then their mortality is risk is really high. But there's no point just doing a random lactate. We need to do a serial lactate just to understand whether actually patient's getting better or worse. And lactate can be actually sampled through venous blood as well, so they're very similar. Whether you've done, obviously arterial sampling is the gold standard, but you can actually look at the venous sample as well. We need to do blood cultures because quite often, when patients are admitted to hospitals with sepsis, we tend to start with a broad spectrum antibiotics just to cover all angles, but blood cultures is really important, and blood cultures should ideally be taken before antimicrobials are administered, because after antibiotics administration, if you're taking blood cultures, the chances of growing any organism can be a lot reduced. So ideally, we should be taking blood cultures before we give antibiotics. And that's because we want to understand, what organism is causing the deterioration, okay, what's causing the infection, so that we can target the organism, once we know it. And that is really good for antibiotics stewardship as well. And when we talk about cultures, we should also remember, sputum, sending sputum, stool, urine for MCNS. These are kind of, that's really important, particularly if the patient comes with respiratory failure, for example, and they're producing sputum, we might want to send them to understand what's actually causing the infection. As part of the treatment therapy, fluids is very, very important sepsis, particularly when the patients are cardiovascularly compromised, if they're hypotensive, and we use fluids. And the recommendation is that, as soon as patients deteriorated hypertensive, we give bolus of about 500 mils of fluid in less than 15 minutes. And what sort of fluid do you give? It's usually crystalloids is what's been recommended. And when we're giving fluids, there's no point just giving fluids. We need to actually monitor patient for response as well, and we need to target, the patient's blood pressure as well. The recommendation at the moment is that we aim for mean arterial pressure about 65 millimeters of mercury, and we might want to achieve that by using fluids and also using the vasopressors. And the recommendation from that 65 millimeters of mercury in sepsis it actually comes from this sepsis spam study, which was published back in 2014, where they compared high target group. They compared patients, and they basically randomized patients to two groups. One group, the patients, we target the mean arterial pressure between 80 to 85. The other group was 65 to 70, and outcome was no difference. Okay, whether you target the mean arterial pressure to 80 versus 65, there's really no difference. The only group of patient who actually benefited from the higher blood pressure, which is mean arterial pressure of 80, was those who have chronic hypertension. So the lesson from this study was that you should aim for mean arterial pressure for 65 in all the patients, but if you know that the patient's got history of hypertension, then we should be aiming for mean arterial pressure of 80 to 85. Okay, so that's the kind of target that we should be aiming for. And fluid comes when you're administering fluid to a patient to address their hemodynamics issues. We give fluids, but fluid can be quite harmful to a patient, and there are now a number of studies actually demonstrating that. So the recommendation is that when in intensive care settings, particularly when we're giving fluids, we need to monitor a response by using either non-invasive cardiac output devices or echo, and so on is a recommendation. And the cautious approach on fluids administration in sepsis has been highlighted through some of the randomized control trial that's been done around sepsis. So if you look at the biggest trials around sepsis and look at the mortality rate, the lowest mortality rate among all the studies was from the ARISE studies. So when you look at compared to other studies, so ARISE study had the lowest mortality rate. And then when you look at the fluids the patient received on that study group was actually the lowest out of all the other studies. And similarly, when you look at the observational studies that was done when you compare survivors versus non-survivors in sepsis, those patients who survived had much lower fluid balance rate than the non-survivors. And this has then hinted that maybe we shouldn't be giving too much fluid to our patients with sepsis. And that has led for the Surviving Sepsis campaign guidelines back in 2021 to revise their guidance and to come up with the recommendation that patients with sepsis who are hyperperfused and in shock, we suggest at least 30 mils per kilogram of IV fluids within the first 3 hours. And obviously, we need to treat individual patients, individually, depending upon their medical history, because the guideline says that give 30 mils per kilo. It doesn't mean that you got to give 30 mils per kilo to all the patients. We need to factor in the patient's medical conditions background. So, for example, if the patient's young, previously fit and well, 20 years old, 30 years old, then yes, you can be less concerned about this giving administrative fluid. But if your patient's quite frail, elderly, with a maybe history of heart failure, then you might want to be a little bit cautious. So, giving 250 mils to 500 mils of bolus and monitoring the response is probably the safe strategy to take when it comes to giving patients fluids. And when we talk about hemodynamics, sort of management of patients, obviously vasopressors are key, right, in sepsis. And we're all very familiar working in intensive care that we use noradrenaline, but usually noradrenaline requires a central access. But again, there has been like drive on practice on whether we can actually give noradrenaline peripherally. And in fact, we've just implemented this practice in my hospital just a few months ago, and this is quite an interesting concept. And previously, in order to administer noradrenaline, you need a central line, right? But quite often, either central line might not be easy to actually do, or it might not be accessible. Or sometimes, it might not be a right thing for the patient to do for a number of reasons. So this is the study actually that highlighted that giving peripheral noradrenaline is actually quite safe. And they have also highlighted that the 50% of the patient that who was enrolled in this study actually didn't require central line, okay, which would have been previously required, if you didn't have a practice of peripheral noradrenaline. So it's an interesting concept to kind of take into consideration as well on managing patients with sepsis. But of course, things to remember is that the dilution of noradrenaline is slightly different. Rather than 4 milligrams to 50 mils of 5% dextrose or normal saline, we have to dilute in 250 mils. So dilution is different, and how we give it is slightly different. And also, you need to be careful about the access. You need decent venous access as well. So it's not just like simply as just giving it into peripherally, but you need to take into consideration our doses as well. But what I'm trying to say is that this is a concept that we should probably take it seriously as well in managing patients with sepsis. And those patients who require vasopressors, the suggestion from the guidelines is that we should also consider giving patients steroid as well, and that's been a recommendation from the Surviving Sepsis Campaign guidelines as well. But when we are managing patients with sepsis, clinical investigation is also really, really important. Not just just a normal sort of CT chest X-ray, so I say, but depending upon where the infection is, the patient might need ultrasound scans, CT scans, or even MRI scans or an echo. I think so. Clinical investigation should be a key part of the management strategy, and that is because they might have they might require source control, they might have abscess and so on. So that's why, it is important to actually do clinical imaging. And the source control is a very, very important thing, because if the patient's got abscess and things, there's no point just keep giving patient antibiotics, because fundamentally the problem is that abscess, and that might need to be drained, okay? And the timing of source control remains controversial, but sooner that you can actually remove the factors that are actually causing infection is obviously better. So source control should also be in the forefront of your mind when we actually managing patients with sepsis. But sepsis doesn't just end in a hospital discharge, or when the patient actually are discharged from intensive care. 50% of the sepsis survivors are affected by what we call post-sepsis syndrome. Patient who develop sepsis might have long-term medical conditions. They might have they might develop neuromuscular weakness. They might have post-traumatic stress disorders. They might have other medical conditions that they develop as a result of sepsis. So life can be really, really hard for the survivors of sepsis. And we actually are known more about post-sepsis syndrome in the recent years than ever before. And there are some key strategies that we can actually implement to actually avoid those long-term conditions. For example, sepsis early care. Sooner we recognize sepsis and treat, obviously going to be beneficial to a patient. But also managing, pain, agitation, and delirium effectively, if the patient's intensive care is really important, because that might just help patient, not to develop, long-term, post-traumatic stress disorders and so on. Early mobilization is seen to be really, really effective, on this for patients' own psychological well-being, but also, keeping neuromuscular strength going. And in the UK, again, we published this Life After Critical Illness document, which is a couple of years ago now, and that's just providing some framework on how we should actually manage patients when they're discharged from intensive care units. So we do quite a follow-up clinics, so where we actually invite patients when they are discharged from intensive care units and gone home. We invite them to give them the opportunity to actually talk to healthcare professionals about their ongoing issues and direct them to seek help as well. And that has been really, really beneficial for patients, mostly from psychologically as well. And you can refer to this document to get some sort of more information. But in terms of prevention side of things of infection and sepsis, obviously, the main ways to prevent infection is to actually implement good infection prevention and control practices in our hospital settings. But you are very familiar with this, the 5 moments of hand hygiene and so on. But that's really, really important. But in intensive care, we should have a timely intervention of care, such as pressure area care, so that the patient don't develop any pressure injuries. Providing good eye care so they don't get any eye-related infections, providing mouth care. Mouth care is really, really important because, the patient might actually silently aspirate into the lungs and develop hospital-acquired or ventilator-associated pneumonias. So providing a good mouth care is really, really important. Working alongside with physiotherapists to provide chest physiotherapy, or respiratory therapists is really, really important to prevent, chest complications. I've already mentioned early mobilization, sitting out patients, good for their chest, good for their, psychological well-being as well. Preventing delirium, having a good sedation practices, so we're not prolonging mechanical ventilation in our patients, and implementing these non-pharmacological measures to promote sleep and so on is, again, really, really important to prevent infection and sepsis. In hospital settings, it's even more important to actually, we prevent, we have in place strategies to actually prevent infection, because when you compare community-acquired infection to hospital-acquired infection, hospital-acquired infection tends to be much more problematic. They tends to be much more resistant, and this is, as you can see here, the types of bacteria that actually causes hospital-acquired pneumonia in compared to community-acquired pneumonia, and there seems to be much more resistance, and there's more difficult to treat. And they're costly as well. So hospital-acquired infection actually far more costly than the community-acquired pneumonia. So from economic perspective as well, it makes a lot of sense to actually implement strategies to actually prevent infections in the first place. Training and education is, again, another really, really important part of preventing infection and managing sepsis. Now, traditionally, we have obviously lecture halls, coming into sessions like this, but actually we've implemented some new strategies on delivering training and education to our staff. We know that all our healthcare professionals are really busy, so rather than asking them to come to training session, we run something called like road shows. We actually go to clinical places, wards, and what you call it, floors, to actually deliver sessions. Okay, and we go to the patients' handovers, for example, and deliver in a 5 minutes or 10 minutes session on sepsis and other medical conditions as well, depending upon what's actually going on, what topics are going on. So we're actually taking education to the wards, and this is the strategy that we use for the last couple of years, and it has been quite effective, and we call it a kind of road show. And it is really important to actually maintain education and training of our staff. And because early identification of sepsis in hospital inpatient by ward nurses, increases 30-day survival. And this is one of the studies that actually proven that, if you invest in training and education in nurses, that you will see the benefit on the patient's sort of mortality and so on. And this particular study demonstrated that reduced mean length of stay in intensive care, decreased 30-day mortalities quite significantly when nurses are able to identify infection really, really earlier on. But we are now moving into times of AI, so I think the jury is still out in terms of how much AI is going to help us to actually detect, patients who are deteriorating. And the meta-analysis actually has not really shown, the research hasn't shown that it makes a huge difference. But I think we're still early days. I think in maybe a couple of years' time, I think we're going to be in a much better place to actually understand what the AI is going to deliver for us. And I think that's probably going to be the future that we need to kind of keep an eye out. But is it all about education and training? No, I don't think it's all about education and training. We can train our nurses and doctors about infection and sepsis, but if there's not enough of them in our floors and in our intensive care unit, then the patient's lives can be at risk. And we know from a number of studies, actually, nurse to patient ratio is really, really important, but not only nurse to patient ratio, but also, patient with we know that the patient with a bachelor's degree, had a significantly lower mortality than the hospital who didn't. So yeah, nurse to patient ratio is really, really important too. Because as we all know that the nurses have got multiple clinical priorities, and sepsis is one of them. So we need to be quite mindful of this as well, because our nurses are actually competing with different priorities in our clinical practice. And safer staffing is really, really important. Not only the evidence shows that it leads to lower mortality, lower hospital-acquired infections, fewer falls in the patients, fewer adverse events, fewer drug errors, and better patient experience. But it's also good for our staff too. It leads to lower stress levels among staff, lower illness and absence rate, better morale, improved retention, and lower burnout rate. So this is why I think safe staffing is really, really important in order to prevent a lot of these complications happening. The Royal College of Nursing have in the UK published a nursing workforce standard, and we are actually the revised version published this year, which actually gives you these 14 key areas that we need to look at in order to promote good a nursing workforce strategy. And again, if you put in Google it and RCN Nursing Workforce Standard, you'll get this document. But again, I'm happy to share the link as well. It just basically gives who's supposed to be accountable and who's supposed to be responsible in your hospitals relating to safe staffing, and how do we provide clinical leadership, what about health, safety, and well-being of staff. All of these things are addressed in this document. But we also need to bring public together as well, and patient and public together when we're actually talking about sepsis, when we want to reduce the complication rate of sepsis, because we want to educate our patients and our public to understand what infection is, what sepsis is, so they can go and seek medical help sooner rather than later. So it is really, really important to have them on board in this journey too. And this is why we've obviously done World Sepsis Day is one of those campaigns. We not only for healthcare professionals but also for public too. And we this is some of the things that we've done in our workplace. We kind of promote things that in newspapers, highlighting what we've done on our World Sepsis Day. For example, this is from a couple of years ago. We actually made a music video and then publicized this through our local media and working with a local choir. We did this, and that kind of generate a lot of kind of media attention, if you like, and people were talking about it, and these are the things that we probably need to do to get the public to understand not just sepsis but other medical conditions too. And the National Health Service in the UK have also provided posters like this to go around on the websites and also in clinical areas. Very simple posters, what sepsis is, sepsis, it just very plain, in a plain language, so lay people can actually understand, where they can get help and so on as well. So these are the strategies that we need to, again, implement in our clinical practice. So I'd just like to close by just giving you my final thought, and this was a quote from 1400. Some philosopher actually mentioned this. Hectic fever at its inception, is difficult to recognize but easy to treat, and left unintended, it becomes easy to recognize but difficult to treat. And 600 years later, I think we haven't really actually moved on much, to be honest. Sepsis remains really difficult to actually recognize, particularly in early stages. But once in a later stage, it is really, really easy to recognize, but then becomes quite difficult to treat. So my final thoughts are that, sepsis remains difficult to recognize in early stages, but difficult to treat in later stages. And what we need in order to improve care in sepsis is, I think, diagnostic tool. We desperately need that, because at the moment the diagnosis relies on clinical judgment, and that can be sometimes problematic, particularly if we've got a not so experienced workforce. We also need to invest in a continuing education and training for our healthcare staff, but we also need to have this standardized approach to screening for sepsis and diagnosis, so that we all kind of doing in the same way. So when we move from one hospital to other, it's actually flows. Okay, but most importantly, I think we need a competent workforce, in our clinical areas, not just adequate in number, but also in skills too, in order to provide safe and effective care. Thank you very much for your attention, and I'm happy to take questions. Over to you, Ella.
All right, thank you, Suman, for enlightening and insightful presentation on the world's fight against sepsis. So we have a lot of questions in our chat box, as well as in our FB Live. So let's tackle first things first. From our very own Sir Erickson Batan, he is asking, "Hi, Suman. How can nursing protocols and sepsis care bundles be standardized to improve consistency and reduce variation in sepsis care across hospital and healthcare settings?"
So I missed that. It just went. Can you repeat that question again, please? Sorry, Wella.
Okay. How can nursing protocols and sepsis care bundles be standardized to improve consistency and reduce variation in sepsis care across hospitals and healthcare settings?
Yes. Yes, that's a really good question. I think how we can standardize is obviously following, the national and international guidelines. And I think a lot of hospitals, I think what we need to do has develop committees, say have like a working group, clinical practice group, or sepsis committees, who actually then group of individuals, not just the medical profession, but actually multidisciplinary team, coming together, reviewing the evidence, and then implementing in clinical practice is actually really, really key. A lot of work I think we have moved on significantly over the last years. I think the variation is actually is not is getting better, I think, but I think there's still a lot of work needs to be done. And also we also need to invest a lot of time and energy and resource in research as well, to understand what the problems are, and also test a lot of theories that are out there. So yeah, investment on studies is really, really important, so that we have got evidence to then put that into our clinical practice.
All right, thank you, sir. Thank you, Suman. So we still have questions in the FB. So from Sir Earl Salavante, he is saying, not all countries have the equal capacity in terms of resources to respond to the sepsis challenge. How do you think these countries are responding to this, and what help are available for those countries?
I think the the help side of things, I think the first thing is we probably need to invest on training and education for our healthcare professionals. I think adopting initial recognition of deteriorating patients, such as the national early warning scores, is probably the way forward, because we all do, the set of observations, and they are not expensive. Doing blood pressures, counting respiratory rate, assessing for patients' neurological status is quite a standard thing. Can be done. Doesn't require any sort of specific, equipment or resources. So I think that is probably the way forward to do this, to implement, national early warning scores, so we can actually look at embed these strategies to actually detect deteriorating patient. Now, it doesn't have to be just for sepsis. It can be for other medical conditions as well. I think that's probably the way forward it is. And investing in training and education of staff is probably the strategy for lower and middle income countries at the moment, because the diagnostics and things are quite expensive, but actually quite often a lot of them are not validated properly, and so yeah, investing on those is probably, I don't think it's warranted at the moment, because of the lack of evidence.
Okay, thank you so much. And we still have questions in the Q&A portion. So the first from Justin Mayriego. The guideline recommends a rapid 500 ml crystalloid bolus within 15 minutes for septic patients with lactate more than 2 mmol per liter or systolic BP of less than 90 millimeter mercury. Given emerging evidence about fluid overload risk and the role of restrictive fluid strategies in sepsis, how should clinicians balance early aggressive fluid resuscitation with the risk of worsening outcomes such as pulmonary edema?
That's an excellent question. I think this is why I think you need to take an individualized approach to managing patients in sepsis as well. As I said on my presentation earlier, that the giving patients, 30 mils per kilo is a kind of standard a guideline, but we should always take into account, patient's medical history and background. So if you are concerned that giving big fluid boluses might be risky for your patient for whatever reason is, you can use other strategies like passive leg raise. So just to kind of lifting the patient's leg up in the air, that you sometimes, well, that usually gives about 500 mils of blood will flow into the heart, and assess the response. You can use that, but it's a really good questions, and can be quite tricky at times, particularly when the patient is frail and elderly. But giving cautious fluid challenge, giving 250 mils, or also utilizing our technology. If you have access to ultrasound scan, if you have access to non-invasive cardiac output devices, is another good way of actually preventing complications as a result of fluid resuscitation and boluses.
All right, thank you. We also have question from Althea Bagon. How should sepsis care be reconstructed to include long-term rehabilitation and socioeconomic support, not just survival-focused acute management?
Excellent question as well. I think we need to focus on preventing infection in first place, and particularly in our communities, in our hospitals. So prevention of infection is probably the key strategies that we need to use. But also we need to go into the back end as well, when the patient actually survived sepsis, and implementing follow-up clinics to actually understand what the patient actually gone through, and also understand the case, what actually led them to deteriorate. Continuous audit research is really, really important to understand what the problem is in our patients, so that we can actually implement changes in our clinical practice.
All right, thank you, Suman. So for the interest of time, we will be entertaining 2 more questions, because I think it's 3 a.m. there, Suman, right?
Yes, yes. It is.
Yeah, so
It's
you
quarter to
can
4 in the morning.
so thank you for your time. So we have question here in the chat box from Keith Ryan Madrigal. What if an institution have no available or limited culture test studies? Is CBC in half or elevated leukocyte level to check the elevated leukocyte level to determine the sepsis and to start an antimicrobial medication?
Yes, well, starting an antibiotics is a clinical decision, and it shouldn't be just based on a blood test, particularly just looking at the single blood test. So we need to look at patients in overall picture, taking into consideration of their medical history, their presenting signs and symptoms, and your physical examination and your clinical judgment. So I think we need to combine all of that to make a decision rather than on a blood test. And at the moment we just don't have a diagnostics to actually give us this answer. For example, if somebody's having a myocardial infarction, we can do troponin, and that actually tells us that can indicate that the patient might be having a heart attack. But unfortunately, we don't have that luxury in sepsis. So it depends on a clinical judgment at the moment. So it shouldn't, the initiation of antimicrobials shouldn't just rely on blood test anyway. So it should be a well-rounded decision based on all the things that I've mentioned, but also talking to microbiologists as well is probably the way forward on this.
Thank you, Soman. One more question. All right. An international standard has been established with regards to how to prevent sepsis. Countries that don't have financial capacity can easily implement. But for the third world countries, countries that have the financial capacity can easily implement. But for the third world countries, it is a big challenge to follow all those standards mentioned. So what is your personal views on this, and do you have any suggestion on how we can improve these issues?
Yes, I mean, it's again a really thoughtful a question, and resource is a very, very important factor, and the developing countries do struggle to implement a lot of changes, and totally understand that. But I think this is why, again, going back to the question earlier on, I think we should invest in education and training and implementing, like early warning scores and so on, and they're kind of simple things to actually implement. I think we should which can actually make a huge difference. It doesn't actually take much resources, because actually detecting deterioration, I think we need to start off with that. But resources is an issue, and we need ongoing investment in research and understanding of how we actually manage patients in developing countries as well. The data that we have around sepsis is actually predominantly based on developed countries as well. So I think investment also needs to be on the research as well on the developing countries, so we have more understanding of the challenges, so that we can actually then implement some changes to actually benefit the local people there. But it's a difficult thing to do, so I appreciate that.
All right. Thank you so much, Suman, for shedding light on the global fight against sepsis. So we will now go to giving of certificate. So we would like to present this certificate of appreciation to you, Suman Shrestha, with the same citation for being our speaker during this webinar. Thank you so much for your time, despite of the time difference that we have. And thank you very much for accepting our request.
Thank you very much, Wella. Thanks for inviting, and it's been a real honor and pleasure to be here with you all. So thank you.
Thank you. Ladies and gentlemen, nurses, Suman Shrestha once again. So before we conclude, I'd like to extend again our heartfelt gratitude to our esteemed speakers for sharing their valuable insights and expertise with us today. Your contribution have enriched our understanding of sepsis care, and will undoubtedly inspire us to make a positive impact in our practice. Thank you once again for sharing your expertise, passion for improving patients' outcome. So with this, all right, so as we bring closer to end of our event, it's my pleasure to invite the esteemed president of the Critical Care Nurses Association of the Philippines Incorporated, Ma'am Maria Isabelita C. Rogado, MAN, RN, FSCCN, to share some final thoughts and reflections on the important discussion we've had today. Notably, Ma'am Bel Rogado has just been honored with the prestigious Lifetime Achievement Award by the World Federation of Critical Care Nurses as a testament to her dedication and contribution to the nursing field. Ladies and gentlemen, let us all welcome Ma'am Bel Rogado.
Hello, good morning to all of you, and thank you very much, Wella, for that very nice introduction, including my recent achievement. So the webinar for sepsis is usually given yearly by the CCNAPI, and this time it is collaborated with the World Federation of Critical Care. It is the aim of both organization to share with you educational component that will increase on your practice in nursing at the bedside, particularly in caring for the critically ill patient. So with this, I hope you tune in more to the World Federation of Critical Care website or in the Facebook, social media, including the CCNAPI, because we have a lot of educational opportunities to which you can avail. So once more, thank you, and I hope you have enjoyed this particular webinar from our two esteemed speaker, Phil and Suman. Thank you. Maraming salamat. Arigato and merci. Bye-bye.
Thank you, Ma'am Bel. So with that, our webinar for this morning comes to a close. So a little bit of reminders for our upcoming events. All right, see you on the World Congress of Intensive and Critical Care, September 16 to 19, 2025 at Vancouver, Canada. With the theme Caring Intensively, let's see you there. All right, we also want to invite those CCNAPI members and PNCS members or the Philippine Neurocritical Care Society on our World Stroke Day with the theme Beyond Golden Hour, Excellence in Stroke Care on October 29, 2025, and CPD units were applied. So we would also like to encourage everyone to be a member of the CCNAPI. Please watch the video on how to be a member. All right, so with that, our webinar for this morning comes to a close. May we depart with a newfound knowledge and renewed sense of hope, inspired to be advocates and assets in improving our healthcare system. Have a blessed day ahead, and let's continue to work together towards a better future for healthcare in our country. Thank you and God bless. Goodbye to our FB audiences in our FB Live. And have a great day. So again, this webinar has been awarded with 2.5 CPD units. And we will be sending you your e-certificate, and this is an example of your World Sepsis Day e-certificate, which you will receive in your email within 5 to 7 working days, provided that you have completed the evaluation and post-test of this webinar, which we will be posting after this. And also, we would like to remind everyone to kindly double check and ensure that you have entered the correct spelling of your names.